I'm Tanny Gray-Thompson. I'm co-chair of Living and Dying Well, a think tank which looks at all the issues around changing the law on assisted suicide. And I'm delighted to be joined by Ilora, Baroness Finlay, who's also a board member of Living and Dying Well. Now, Ilora, you're a professor of palliative care, and we're going to be talking not just about assisted suicide and assisted dying, but about the relationship with doctors and how potentially changing the law can affect that. So we've been told that where assisted dying has been legalised, people continue to trust their doctors. What do you have to say to that?
Well, I think if you look all around the world, people trust their doctors actually because they have to. When you're ill and you need help, you will trust somebody who's offering to help you. Actually, I'm afraid to say we know that people will trust bad doctors as well as good doctors. It's nothing to do with the quality of the doctor. It's often their communication skills and the fact that people are desperate. So I don't put much store by that, I'm afraid. I think people are ill all over the world. And doctors have to realise the power differential that they hold.
And what we're talking about, any potential change in the law in the UK is talking about physician-assisted suicide, which means the doctor would help somebody to die, as opposed to other jurisdictions where people are given the drugs to take at home. How would physician-assisted suicide change the relationship between a patient and a doctor? Because there are people who said, oh, it's just a small change. It's not a big deal.
I think it's a huge change, and you have to look at what do doctors do and how does the law work now. If you're a doctor and you're faced with somebody who's desperately ill and clearly dying, you discuss things openly with them. You have open conversations, explain what the options are, explain to the family how things are looking as well, that they're not going well. And you can withdraw, in fact, you should withdraw treatment which is futile, which is not achieving its end. But you must look after that person while they're dying. What such a law does is it suddenly says, well, you're looking after somebody and you're doing all you can to improve their quality of life and improve their situation. But when they ask about having lethal drugs, you stop doing that and you suddenly think about giving them something to end their life. You may know that there's a lot more that you could do to improve them. And the minute you go down the road of saying, well, yes, I'll accede to your request, you're endorsing all of their fears. And you're also saying, actually, this is the best option for you. I also worry that it would be very easy, and in fact, it does sound from jurisdictions, from doctors I've spoken to, that it can be very easy to go down that road very early on. So this isn't just about people in the last days or hours of life. Very often these requests are coming from people much earlier in their disease. They're frightened of things which might happen, but most patients are frightened of things which probably won't happen. And they need to know what your plans are to deal with events. If you respond to their fear by saying, I'll give you lethal drugs and we'll process that, you're saying, I agree with you, but you're also not giving the information about alternative options. I think the other thing that I've seen happen is that the doctor gets locked into one pathway or another pathway. It's very difficult to go in two directions at once. So it's very difficult to work to improve quality of life, to help someone find quality and ways of living, and at the same time be processing their lethal drugs.
So ultimately, if the UK was to go down the route of physician-assisted suicide, do you think it would affect end-of-life care, palliative care funding, in terms of helping support people at a time which is seen as quite difficult?
I think it would fundamentally affect the way that people view an approach to end-of-life care. I do worry that, given that most of our palliative care is in the charitable sector at the moment, through hospices, that there would be a fall in people giving. And actually, during the COVID pandemic, we've seen hospices in terrible financial straits, and they've had money from the government because otherwise they would have closed. But remember, palliative care is an approach, and most people's palliative care comes from other people, from doctors and nurses, wherever they are, not just specialist palliative care. So if you change the attitudes across the piece, there'll be patients who never even get to access specialist palliative care, because why would they? They've asked about having lethal drugs, and there are pressures on beds, and there are pressures on money. And I think it would be very, very easy to just give in to seeing this as a financial expedient as well, I'm afraid.
Can you talk a bit more about end-of-life care? I think it's one of those phrases that we hear a lot, but people may not necessarily understand exactly, what's involved, because, how much can a person nearing the end of life expect from palliative care doctors?
Well, of course, end-of-life care often begins months or even years before somebody actually dies. Many people have got a diagnosis which is not going to be curable. Their disease is going to be progressive. And the role of clinical care overall is to do all we can to improve their quality of life, keep complications and problems at bay. So when you're getting to the end stage of your disease, you may need much more intensive input, but different things can happen. You might go downhill steadily. You might have a sudden crisis, which means that you need a sudden intervention. And if you think ahead, you may see something where suddenly the pace of the disease is changing, and that needs intervention there and then. Now, specialist palliative care during the COVID pandemic has worked alongside services, because we've all realized that we're living with uncertainty. So keeping people comfortable all the way through their disease is really important. There's no point just having an intervention in the last days of life, because you'll have missed months of opportunity to improve the way that people live. But of course, the reality is that we're all going to die, and we must accept death. And that is another aspect of palliative care, which is talking openly with people about what they want, what they need, and about their own dying, and how we can manage it to be peaceful and gentle.
So do you think it's true that under existing laws, it's very difficult for doctors to have that open and frank discussion with patients about dying?
Not at all. I think it's the opposite. Doctors have very open, frank conversations. There are some people, intensivists, are having very open, frank conversations with patients. And you will have seen things on the television. Matt Morgan's written a book, Critical, about encounters in intensive care, describing really in-depth, beautiful conversations, very sensitively conducted with people who are dying. I've had patients talk to me very, very openly about dying for many years. There are inhibitions in our society who don't like to talk about dying because they think it might make it a self-fulfilling prophecy. That's different. But our law allows doctors to talk as openly as a patient wants.
So one of the reasons that's been given for physician-assisted suicide is to avoid a painful and undignified death. Maybe perhaps because of a bad experience with a relative, but can palliative care doctors provide a comfortable and dignified death?
Can I take the two bits first? First of all, people, yes, may have had a bad experience with a relative. I'm afraid to say that people did have bad experiences often in the past. And that's what the specialty of palliative care has been working to avoid for years, and to try to improve standards of care. The other thing is that emergencies happen. People have road accidents, they have an operation, complications, things go wrong. COVID has shown us how unpredictable life is. So whilst you can strive in medicine, there is nothing in medicine that's 100%. But what we do know is that of so many thousands of patients that get referred to specialist palliative care when other clinicians have felt there's nothing more they can do, that there is something more that we can do, that we can manage things differently, get on top of pain, get on top of symptoms. And interestingly, if you look at the data from Oregon, where they've looked at assisted suicide, uncontrolled pain or fear of pain in the future comes way down the list. Even there, it's not prominent, and they don't have the type of services that we have.
I mean, another reason that's been given for bringing in or changing the law is the cost of end-of-life care. What do you think can be done to enable everyone to have access to, good quality end-of-life care?
Actually, good quality end-of-life care costs less than poor quality care, and there's some really good studies to show it. When you're looking after people well, they need less intervention. You don't have things done which are unnecessary, and the costs are lower. So good palliative care, good care does not cost more money.
One of the other things that we hear quite a lot is about choice, that people need to have choice. So why can't someone nearing the end of their life choose when they die? Why isn't there, and again, it's another phrase we hear a lot, why isn't there a right to die?
Well, I'm afraid nobody can avoid death. There is a right to die. We're all going to die. What there isn't is a right to have somebody end your life. There isn't a right to be killed. In terms of choice, it is actually the biggest choice that people want is to not be ill in the first place, but that can't be avoided. But then the things that matter, the things that break a person's spirit, are what might appear to be little things, but where they're not given choice, where they're not given control, and where they're not treated with respect. And the answer to that is not to end their lives. The answer is to make sure that everybody is treated with the respect and care, that no value judgments are made about them, and that they can access help and support on a 24/7 basis. And I think that's something we have to tackle. And I hope the next lot of healthcare legislation will really tackle the problem of inadequate out-of-hours services. But you don't solve inadequate out-of-hours services by deciding that doctors can give lethal drugs to their patients to end their lives.
So if we take this to the next step, supposing somebody has been told they've got 6 months to live, shouldn't they be allowed to then have a choice about how they end their life?
Well, the first thing I want to say is that nobody can predict prognosis. All of these estimates are based on averages across the population. What a patient wants to know is where are they on that range? And you just can't tell. I've had patients who I thought would be dead in weeks and they've been alive months later. I've had somebody who I thought would be dead in 3 months, and 2 decades later, he's still alive and doing well. I've had other people who we thought would live for 6, 8 months, and they died really quickly. You just can't tell. What you need to do is put all the plans in place to provide all the care and look at what might happen, where a crisis might be averted, and then provide all that care. But you can't mark off in your diary when the end of your life is going to come. The tragedy, if you do that, is that you may well cut short your life by months or years and miss out on really important times. And I've been astonished the number of times relatives say, I never believed that those last 2 or 3 days when we thought everything was over would be so important. We suddenly had an important conversation. However much people plan, the unexpected happens, and that can be the most important memory for a family.
Laura, thank you very much for your time and also sharing your expertise. Thank you.
Thank you.